And we're back. We have Callum East for the first time on the podcast. Callum, I'm sure some people listening know who you are, but for the people who don't, can you tell us a little bit about yourself?
Yeah, I mean, thanks for first off inviting me onto this podcast, Chris, because I've been listening to your podcast for a while, and I was just telling you before we came on how popular your podcast is in the UK in particular. So stoked and privileged to be on the podcast. So thanks for inviting me. Um, yeah, my name's Callum. I'm a UK trained physiotherapist. Recently moved to Australia with my wife only about 4 months ago. So I'm still in kind of that transition of healthcare models, but did all my training in the UK. I've been in the industry now for coming up to about 11 years. Did my master's degree in the UK as well. And yeah, worked in the NHS in England in primary care, in private practice, in sport. My current role now, I was just saying to you, Chris, is split between two places. So I'm in a medical center a few days a week. So dealing with more complex medical clinical caseloads. And then 2 days a week, I'm in a high performance center, which for anyone that knows the West Coast Eagles and AFL, Australian Football League side, that's where they're based. So very different demographic that comes in through there. As a full-time physiotherapist in both places. Enjoy training. I'm someone that's riddled with injuries from my years in sport. So I've got set of tendon issues, I've got hip issues, probably which drove my interest in hips. And to be honest, just enjoying Perth, enjoying the warmer, sunnier climate compared to that of the UK. So I think I've got a bit more colour to my skin. I've been told I'm looking healthier by friends. So if that transpires onto this video here. So that's it's a little bit about me.
Yeah, you alluded to it a little bit. It seems like your specialty and your clinical interests surround the hip, and that's going to be the conversation for today. Was that interest mainly from the injuries you accrued, or as you went through physio program, you just kind of niched down? How did you get into it?
Yeah, I think part of it is going to be the injuries I sustained when I was competing in sport, but I think the interest for me was more driven in the complexity of the hip. And this was in the UK. I would speak to a lot of physios, and they would be terrified of the hip because it's so complex. But that drove me to learn much more about it in thinking I want to understand this complexity. And dare I say, can we even simplify it to people that are terrified of it? So a lot of it came down to that and me being a bit nerdy and a bit geeky and wanting to understand it more. Teaching and mentoring and helping other clinicians develop with their hip knowledge and assessments rehab. So it was probably more largely driven on that. And kind of my side injuries to that was probably secondary, I suppose.
Yeah, well, the more specific hip-related topic today is going to be on avascular necrosis of the hip. And I reached out to you specifically because on your Instagram, you had this kind of proposed tool or acronym essentially for identifying or having a higher probability of avascular necrosis. And we've had plenty of hip-related conversations with previous guests, and those have been great. Mehmet Cem, Mark Sertica, we've had surgeon on, we've had gluteal tendinopathy-based conversations, athletic groin pain, things in and around the hip, but we haven't really dived into more concerning red flags and ways to think through those. So I think your kind of screening tool, or this mnemonic, as I should say, is going to be really helpful to chat through and see and hear more of the specifics. So can you start with maybe the mnemonic itself, what it stands for, and then we can kind of go down through each one?
Yeah, definitely. So this was something I put out on social media. It's probably about a month ago now. It all came from me putting out an original post, which was a reel to help people identify avascular necrosis, which I know we'll go into in a minute. But I got a lot of feedback, constructive feedback from people on that, because in the UK, we use an acronym called STARS, which is still apparent in this new mnemonic that I've created. But it was a way to help people identify some key subjective factors or parameters to increase their clinical suspicion on if someone could have an AVN. And I put it out there, got a lot of likes to it, but there was a lot of feedback, and actually from students who had messaged me privately saying, "Oh, Callum, you put out a post this many months ago. You also mentioned this." And there was another question said, "Oh, does this not? Because you mentioned this in another post." So I realized that STARS acronym or mnemonic didn't cover everything that we needed to cover. So that's what prompted me to try and think of something different that was more up to date. So I've called it STARS P. The P, I'll just explain that in just a second. It's a little bit more focused into the hip because it's a bit of a pun, isn't it? And if someone is struggling to climb the stairs, then think AVN. But I think this mnemonic can be applicable to other areas like the shoulder, foot and ankle as well. So breaking it down, the S stands for steroids. and then also smoking as well. So this was something that was in the original mnemonic, and it stays true to that. The T stands for trauma, which we'll go into. So talking about any, and related to the hip, it's any type of trauma that can happen at the hip. The A stands for alcohol. So talking about alcohol abuse, alcoholism, sort of in that realm. I stands for infection. So we'll go into particular like septic arthritis or osteomyelitis, and that wasn't in the old mnemonics. That was something additional that we had. The R is for rheumatology, rheumatological diseases. And we've also put in there radiation, which I did talk about in the original mnemonic, but I suppose when the mnemonic was developed, it only mentioned rheumatology. It didn't really touch on radiation. So we've also added that into the mix. And the S, which was in the original mnemonic, stands for sickle cell disease. Not a common finding, I suppose, more talking in the UK. It wasn't something that you would commonly see. The P stands for pregnancy. And we'll touch on this in the podcast as well, because it's very, very rare for someone to get AVN or for a pregnant lady to get AVN, but it is still part of a small set of risk factors. So that's why it's called STAIRS with a hyphen P on the end to acknowledge that. And that's the new mnemonic and what it all stands for.
Yeah, before we dive into each one, can you just describe what is avascular necrosis? And if we say AVN, we're using those synonymously, but what is avascular necrosis?
Yeah, so if we're just breaking down, and I say this to students as well, is that if we use the word avascular, avascular just means lack of or no blood supply. And necrosis is essentially the Latin for cell death, cellular death. So if we put it all together, AVN is essentially, in the context of a joint here and the hip joint, we're saying that AVN is death of bone tissue, which is caused by insufficient blood supply. So if any of those categories that we mentioned in the mnemonic, if any of those are damaging or compressing or blocking the very small, delicate set of arteries in particular that supply the hip joint, you get a lack of supply to the bones and to the joint. So those bone cells, or our osteocytes, will start to die within hours. So if it goes undetected or untreated over a period of weeks to months, the bone, the joints will essentially become weaker and weaker. They will start to lose their structural integrity. And if we're looking at the femoral head-neck junction specifically, it can then eventually collapse if it goes undetected, untreated, and that becomes a surgical emergency. So that's I suppose what we mean by AVN specifically to the hip.
Is hip AVN one of the more common joints or places of the body that can have avascular necrosis?
Yeah, it's up there, I suppose, alongside the shoulder as well. And I think it's because, and we'll go into this actually when we break it each down, but particularly in your proximal femur, your femoral neck, your pelvis, there's a lot of trabecular bone or spongy bone, fatty marrow, depends which sort of textbook you read. And that's the structure within, I suppose, the bone that gets massively affected, because that's where all the microvascular structures are. So when we're talking about microvascular damage or interruption, it's going to more commonly happen, or it's going to be a bigger risk to those bones that have a lot more spongy bone, fatty marrow. So yes, the hip joint, the neck of femur is up there with common places where if AVN is going to happen, it can certainly happen in that joint.
And relating that to a previous conversation with Steph Munt and some other researchers or clinicians around bone stress injuries, the femoral neck is considered a high-risk site because of one of the reasons, because that more poor blood supply as well. Is that kind of a correct comparison or a reason why it's also kind of a high-risk stress fracture site?
Yeah, that's exactly it. Yeah, the neck of femur, yeah, the pubic region, the sacrum as well. They may have mentioned that these are all high risk bone stress injury sites where they say that if there's a bone stress injury, number one, it's more likely to happen there. Two, it's more likely to progress very quickly, more likely to lead to a fracture. There's more likely to be non-union in terms of healing, fracture healing, all for those reasons that we've just covered. Absolutely. So I would say there is a direct link, yes, there between bone stress injury and AVN, talking about vascular supply.
The everyday clinician that's listening to this that has a referral, a patient, maybe the note just says hip pain, maybe there's some imaging findings, maybe not, maybe there's information of what's going on maybe a specific trauma, whatever it is, but someone may be presented with no information besides their hip hurts, and they're trying to go in real time through this differential diagnosis of all of the possible things. And ideally, clinicians are trying to, at the beginning, decide if someone's appropriate for rehab and whether or not there's red flags that should be ruled out. And AVN should be one of them. But a lot of times in education and just clinically, it's hard to think through that and figure out, okay, what are the things that I should be diving more into? And I think these mnemonic is going to be really helpful for people to just have in the back of their head and to think through these specific questions and considerations. So you mentioned stairs P as the mnemonic, the first one S being for steroids and smoking. Let's start there. From steroids, you can start, what are we asking? What are we factoring in? Why is that a risk factor? And then we can go into smoking after that.
Yeah, definitely. So yeah, we'll go into steroids, and I suppose I'm probably grabbing my roles as a first contact physio in primary care from the UK, where you've used your example. A lot of patients in a first contact role would not come in with scans. You're the first physio there, or first professional that they're seeing. And that may be the case anywhere in the world, that if you're that first person, I said to you before we started the podcast, we're kind of detectives. That's how I see us as musculoskeletal practitioners. We're kind of that medical detective. So when we're looking at steroids, you'd be leaning on the past medical history quite a bit. So if someone says to you, for example, that they've got COPD, or chronic obstructive pulmonary disease, or if they've got a rheumatological condition like rheumatoid arthritis, and they might be on prednisolone, which is a form of corticosteroid, because a lot of these patients require a form of steroid medication to help them manage their chronic longer term condition. So if they've been on long-term steroids, you're automatically thinking, I need to consider AVN as part of my differentials because I know long-term steroid medications, or if they've had repeated intra-articular steroid injections, not just at the hip, but anywhere, your light starts to go on a little bit. So in terms of why that's a risk factor, steroids has been recognized as a primary risk factor in the development of AVN, and this one's quite well known. And I suppose there's been three physiological, biological theories as to why that's the case. The first one is that steroids, they will alter lipid metabolism. So I mentioned just a minute ago that particularly within your pelvis, your proximal femur, we have a lot of trabecular bone, a lot of spongy bone, fatty marrow. So we have a lot of fatty cells. And particularly within these bones, in adults, 50 to 70% of your trabecular bone is made up of fatty cells. So if you've got altered lipid metabolism, what essentially that does is those fatty cells then start to swell, or if we're being scientific, they'll start to hypertrophy, get much bigger. And if 50 to 70% of those of our trabecular bone is fatty cells, you can imagine everything's ballooning up within that bone. So you then get an increase in intraosseous pressure. So the pressure within the bone will start to elevate. And that pressure can then start to cause a blockage to the blood vessels that are then trying to supply blood to that bone. And obviously that blockage then means blood can't simply get to the bone. So if we bring it back to avascular, that's your avascular element that then gets caused. The second part is emboli formation. So I tend to keep this simple in the sense, if we think about cardiovascular diseases like arteriosclerosis, and we can get emboli that forms within the blood vessels, right? And it blocks, this is for cardiovascular related diseases to the heart, and it blocks blood going towards the heart. It's the same concept. So the steroids, if they're causing emboli formation physiologically within our blood vessels, that will then start to inhibit blood getting towards the bone. And the final one is actual damage to the blood vessels themselves. So the little inner lining, the endothelium that we are all taught at university, is the very inner lining of the blood vessel. That can then be damaged as a direct result from the steroids as well. So if you put all of this together, that's what is going to be inhibiting blood flow to the bone, which can then lead to the necrosis over time.
And you mentioned both, I think you said for the example of rheumatological disease, like an oral steroid or intra-articular steroid injection. Are one of those considered maybe more of a risk factor? I know they're both primary risk factors, but one more concerning. And then from an injection perspective, is there quite a high risk even with one kind of intra-articular injection, or is it these repeat cases that just continue to exponentially increase the probability?
Yeah, I'd say it's the latter. So if someone's had one intra-articular injection, the chances are it's far less likely that they're going to go on to develop an AVN. It has to be acknowledged by the injecting practitioner as a risk, and they obviously have to avoid kinking any nerves and blood vessels. But I would say that it is going to be much more down to the chronic use of steroid medications, or if for whatever reason, and this shouldn't be happening in my opinion clinically, if someone's having repeated intra-articular steroid joint injections, I mean, look, that should not be happening anyway, in my opinion. That's why most experts will talk about one or two, because they're not actually injecting a massive amount of steroid into the joint with just one injection. So you shouldn't then, it's far less likely an AVM will result. So I would be more concerned with someone that's been on far long-term steroid medications. If I've got a 50-year-old female that was diagnosed with juvenile arthritis and then she's been diagnosed with rheumatoid arthritis, from the age of 18, 19, whatever, and then for the past 20 to 30 years, she's been on long-term steroid medications, that's more concerning to me than just one steroid injection.
Is in that example, if someone maybe had juvenile rheumatoid arthritis, then adult rheumatoid arthritis, and they're on these chronically, are there medications that they can take that of that are less impactful, or it's just this is kind of the options that they have, and they're all, especially if they're taken chronically, elevating risk?
Yeah, look, to be honest, it's probably outside of my scope to comment directly on types of medications or names of medications. It's not something I've done a massive amount of training in. I'm just aware of some of the medications they can take. And I'm probably more talking anecdotally here, that when I have seen not just RA, but any type of rheumatological case, they are on a form of steroid medication. If the question is which steroid medication leads to increased risk to AVN, that's probably not something that I'm in the best position to answer that. So I'd be more looking on, is it a steroid medication, which normally it is, but what is the prescription of it? That would probably be more so looking at the dosage, right? So if someone's on, let's call it 2 grams a day, but they take it every day, 7 days a week, every month of every year, versus someone that may only take it as prescribed as and when it's needed, maybe the rheumatologist would say, or they might say, look, you only need to take this on 2 evenings a week after a meal. So I'd probably be more looking at the dosage, more of the extreme example of if someone's taking a certain dosage every single day of the week versus someone that it might just be 1 evening a week or 2 evenings a week or sporadically as needed, there's probably greater risk on that person that's been prescribed it to take every single day.
Yeah, that makes perfect sense. Let's go into the second S, smoking. What is the risk factor there? May seem obvious, but yeah, elaborate on smoking.
Yeah, I think students, qualified professionals will be a bit more familiar with smoking because it's something that we will be all more familiar with in terms of the biology that's there. But again, three things that I would outline that can contribute. The first one is vasoconstriction, which we know that's what smoking does. So for anyone that hasn't heard the term vasoconstriction, in simple terms, it just basically means the space in your blood vessels narrowing, becoming thicker, the space becoming smaller, tighter. That's vasoconstriction, whereas dilation is essentially things opening back up again, so allowing for more space through the arteries. So smoking causes vasoconstriction, and the nicotine is what's thought to be a direct contributor to that. So if you've got a constricted blood vessel, you're reducing efficient blood flow or blocking blood flow to any given region. The other thing that it does is it increases blood viscosity. So viscosity just meaning that the blood will become stickier, much thicker. Think of it when you're caramelizing sugar type thing, it becomes very, very sticky. It doesn't run very well. And that will also affect how well blood will flow to any given region, because ideally you want it more watery so it can flow much, much easier. And the other one, which everyone will be more familiar with as well, is reduced oxygen delivery. So that's down to the carbon monoxide that comes on as a byproduct or a side effect from smoking. That's going to reduce the oxygen transportation that exists within our hemoglobin, that's our hemoglobin in our red blood cells. It's going to reduce that oxygen delivery, which is what our bones need, is what all of our tissues need to survive. So if you've got someone, so if you apply that clinically, if you've got someone comes in and you ask them about their current medical history, their past medical history, and someone says, yeah, I smoke 20 cigarettes a day. Even if someone says, and I've had this recently here in Australia, someone says, oh, I used to smoke 20 cigarettes a day. I'm then asking, well, how long were you doing that for? Now, this particular gentleman was in his mid 40s. He said he started from the age of 16 or 17. We'll just call it, he was about 45, and he only stopped smoking about 2 years ago. But you got to think, there was decades there where he was smoking 20 cigarettes a day. So just because he's now stopped in the last 2 years, he still had a couple of decades of causing this biology, if you like, to his body, that many would argue after that many years of smoking 20 a day is probably irreversible. So it doesn't mean he's any less risk of getting an AVN, just because he's now stopped. So you've always got to ask, are you still smoking? And if they say, no, I quit, when did you quit? And when you were smoking, how much were you smoking a day?
Let's go to stairs, S, steroid smoking. Let's go to T, trauma. Type of trauma, does it, matter? What specific questions are you asking? And this may be a good time to also reflect on, typically when patients are coming in and you have, this differential you're going through, you're asking these questions, but also physically you're seeing or assessing things with someone maybe that you've seen or that can present with AVN. What are they maybe describing? Are you seeing? Are you physically performing that is maybe leaning you as well towards the suspicion of AVN?
Yeah. So if someone's come into the clinic, and you may, if you work in sport, you might see this as well. Like something's happened on match day, the next day they've come in to see you. So if there's been a very specific mechanism, so if you take rugby, someone's jumped, landed, or collided, they've gone down. If when they went down, they were in severe pain, they had to retire from playing, and particularly if we're talking about the hip, they couldn't weight bear on the leg. That tells us something's happened to the joints. If someone can't weight bear, chances are in a traumatic instance, something has probably happened to that joint. But it's often quite good to leave it 24, 48 hours to let everything settle down, let the adrenaline calm down, and then they come into your clinic. So if there has been a mechanism of injury that they describe to you, that is something traumatic. I mean, there's your tick. If someone comes in limping, that's a key giveaway sign. And when I'm teaching or talking and we're trying to differentiate, is it the lower back versus the hip when we talk about referred pain? If someone's limping, the chances are that's going to be the hip. It's not going to be the lower back. So yeah, if they come in limping, that's a key problem. If they felt that they've had to use a stick or a crutch to help them, that again is a problem. I've seen a dislocated, or this was in my sporting days, a couple of dislocated hips. And what we found, and I found this in the literature as well, that if you find someone, you can lay them on their back if they're able to. If there is a clear leg length discrepancy, now this doesn't mean leg length discrepancy is bad. We're not talking about just little nuances in one leg slightly shorter than the other. If there is a distinct leg length discrepancy, and in particular, if someone's leg has been externally rotated, and that's where it falls. I've had two cases in that. One was sport. One was just out in a shopping center. Lady fell over, hip dislocations. So that then became a thing of, if someone has had a traumatic incident, a fall, attack, or whatever, there is a clear leg length discrepancy, and that leg that's injured has fallen out into an external rotated position, and they just can't get it back through because it's too painful. Something's happened to that hip joint, possibly a dislocation, possibly a fracture. If you aren't seeing that, because it's not quite as severe as that, if someone's lost range of movement in their hip, both passively and actively, if it's very deep groin pain, buttock pain, thigh pain, these are all the kind of clinical signs where you're thinking something has got to have happened to that hip joint that probably needs further investigation. So that would be the observations or some of the clinical signs to look for. The type of injury that increases the risk to AVN would be a neck of femur fracture or a posterior dislocation. They're probably the two key ones that I would outline to people. Either of those two injuries can cause a tearing of the blood vessels that supply the hip joint or the femoral head neck junction. I use the term kink. So sometimes it can kink them. So it hasn't torn them. It's maybe shifted them anatomically out of position, if you like. And the other thing as well that we would expect is it causes swelling to the joint. So that inflammatory response, that synovitis that happens, can all cause a blockage to the blood vessels trying to supply blood to the joint.
And this trauma, like you said, if it's maybe a femoral neck fracture or a posterior dislocation, and that's elevating the risk of avascular necrosis, does that AVN happen relatively quickly, as in it can start within, moments after the event, or this is still kind of a gradual onset over days, weeks, months that starts to occur, or it could be both?
Yeah, it could be both, but I would say that this is an incident with trauma where there's much more risk for it happening much quicker. So if we use the steroids example or the smoker example, that's something that will probably happen over months. Whereas if you've had a traumatic incident, it's a bit like losing a pulse as well. So that's something that in physio, sports medicine, orthopedics, if you're working in rugby, for example, and there's been a significant trauma, we're taught to in immediate care or trauma to check pulses. So in that instance, you would try and check the femoral pulse and the popliteal pulse because you're looking for diminishes in pulses one side to the other. If you're starting to see pallor as well and colding and discoloration in the skin, that's something that can happen very quick after a trauma. So if we use it in that context to say if someone's blood supply can get interrupted after a trauma quite quickly, then the idea of avascular necrosis happening quite quickly because of lack of blood supply to the joint can also happen quite quickly after a trauma. So in those two separated instances, I'd probably say someone that's had a significant trauma to the hip, you'd be more worried about AVN happening quicker compared to someone that's atraumatic and they've been on steroid medications for many years. That's probably going to be a slower progression.
And obviously a trauma, that referral to imaging may be quicker in general, whether or not you're suspicious of an AVN, just you're suspicious of, a fracture or something else occurring. In general, for imaging and maybe the gold standard for assessing whether or not AVN is present, is it MRI? Can it occur through X-ray, through CT? What's the general recommendation?
Yeah, generally, I'm speaking more on behalf of the UK here because I don't want to say it's the same here in Australia as I'm still getting to know things. But orthopedics like an X-ray first and foremost because it's very cheap, it's very easily accessible, and you can catch an AVN in an X-ray. I would probably say that it's something you will detect more in the mid to later stages. I said earlier, you get the bone marrow edema, but then you start to lose structural integrity, and in the case of the femoral head, it can then collapse. So where the joint starts to lose its structural integrity and density, that's something that an X-ray would likely pick up. What the X-ray wouldn't pick up is the bone marrow changes that happen first. So normally, if you see nothing on the X-ray, we would follow that up with an MRI because the very early stages of AVN will be that bone marrow edema. And that's something the MRI will pick up that the X-ray will miss. Start with the X-ray. It's cheap. It's easy to get a hold of. I'll probably follow up with the MRI. If you've got a patient in your clinic that with this mnemonic, they start to tick several boxes and you absolutely want to rule it out, we would follow up with an MRI.
Anything else with trauma, or do you want to go to alcohol?
No, if there's no, that's a loaded question. No, we'll leave it there.
Okay, fair enough. Alcohol, what's the concern there? How are you framing the question or asking people about their intake?
Yeah, and that's actually a really important question because I suppose in a similar way, when we talk to people about weight management as well, that's really hard to talk about because you don't want to risk upsetting people. So how you would frame it to the individual, you've got to, like in my opinion, you don't just want to jump in and ask them, how much alcohol do you drink a week? Because straight away they'll go, whoa, okay, why are you asking me that? So sometimes you might be wanting to look for an opening. Yeah. So if someone is saying, this is anecdotal now. So if someone says to me, I've been having quite a stressful time at work, actually, been sort of struggling, finances, I'm injured, but I'm still having to work because I've got to make rent, things like that. And I might say to them, how are you relaxing? What are you trying to do to relax? And I've had people say, look, I just sit down of an evening, like I might have a glass of wine. I might just have a pint of an evening type thing to help me unwind. And there's an opening. And you might just say, oh, okay, so what do you like to drink then? You mentioned wine, and you might try and find some common ground and say, oh, is it like a Merlot? Well, what do you like to drink? And they might tell you, and you say, okay, is that just a glass of an evening then that you're having? And then you're opening up for them to tell you a little bit more. So I always go around the route of you want the patient to feel invited to speak. They shouldn't feel as though you're interrogating them as if you're trying to find something out. We know we are, but they need to be invited to share their story. And sometimes there isn't an opening for that. Sometimes I've seen in the patient's medical history that a GP has documented that this person has a history of alcohol abuse or excessive alcohol intake. So already I know I don't need to jump down that rabbit hole. So there isn't a script here that I would necessarily, this is what you need to do. I would just go in with the framework of thinking someone needs to feel invited to share their story with you. And if there is an opportunity for them to be invited, we take hold of it. Don't just jump in and say, look, do you drink? How much do you drink per week? That can come across quite as an interrogation. So that's how I would go about sort of framing that. If we jump to the scientific issues with alcohol, it's actually very, very similar to what we covered with the steroids medication in terms of scientific reasons. So as a recap, if you've got excess ethanol within the bloodstream, that can also, like steroids, cause fatty cell hypertrophy within your bones, particularly the pelvic bones that we spoke about. There's a lot of them. So that swelling, that hypertrophy will increase your intraosseous pressure, and that will then block blood supply to those bones. Emboli formation. So we know that if you think of alcohol as being a risk factor for cardiovascular diseases, and part of that is damage to the lining of your blood vessels, as well as the buildup of emboli within the blood vessels. So all of that reduces blood flow, reduces efficiency of blood flow to the bones. But the other thing as well is the direct toxicity as well that comes, the toxic acidic environment that alcohol will have on your vascular system that can damage bones directly. It can damage the blood vessels directly. So that's where we're concerned on a scientific level, very, very similar to the steroids.
Let's go into eye infection. Is this local hip infection? Can this be any infection throughout the body? What does that look like? And then what are the risks?
Yeah, so there's, I suppose, in our differentials, which we might talk about in a bit, septic arthritis is one of your differentials. Because it's the other thing, I'll probably close out this podcast with this, is that I'm not saying today that it is the responsibility of the physio, the osteopath, the chiropractor. It's not your responsibility to diagnose avascular necrosis. It's your responsibility to build up a clinical picture and then refer on immediately. So a lot of things will look very similar here. There's a lot of differential. We'll talk about it, but none of them have got distinct objective patterns. So that's the important thing that I want to raise. But if we're talking about septic arthritis as a differentiator, there are two different types. So one that I think a lot of us are aware of is a prosthetic joint infection. So this would be after just call it a total hip replacement as an example. I would say that this is quite rare now, these sort of post-op prosthetic joint infections, simply because surgical techniques have advanced massively. The sterile protocols have also advanced. And I would say we can speak on behalf of our orthopedic colleagues. They're very, very good at maintaining and keeping with those sterile protocols. So it's very, very rare. I don't think I've seen one actually, a post-op septic arthritis, a prosthetic joint infection after any procedure. So that's how rare it is. The more common one, we call it as a native joint septic arthritis. So when we say that, we just mean that an infection has happened in someone's own joint. And that can usually, it's come from bacteria traveling through the bloodstream. So it can happen from penetration into the skin. It can happen through an IV line. So if someone happened to be in hospital recently and they were fitted with an IV line, urinary tract. So urinary tract infections, which I would probably say that's probably the most common type of infection that I've seen clinically, or a respiratory system infection. So if you happen to be working with someone that recently had pneumonia, or if they've got emphysema or asthma, something like that, they're at an increased risk of infection. So that's how a native infection can happen. It's essentially a bacteria that's entered the bloodstream through any of those means, and it's a metastasized, targeted joint. The three most common joints where it happens is the hip, is the knee, and the shoulder. Those are the three most common ones where it happens. People that have got an underlying joint disease, like rheumatoid arthritis, are at a higher risk. People that are on immunosuppression medications because their immune system is compromised already. Diabetics, their immune system is also more compromised than someone that doesn't have diabetes. And anyone that's recently had a skin infection or has recently had a more systemic illness. So this all comes back to your subjective assessment, which if I can hone in on anything today to anyone, it's master your subjective. All of this will be revealed in the patient's, not only their symptoms, but their current medical history, their past medical history, the social factors. if you have someone that's got rheumatoid arthritis and you think, okay, so that already means they're immune compromised and something more systemic is going on. They're on corticosteroid medications. If they've recently been to a country where they've had let's just call it, they've recently gone to Africa, for example, they've had a sting or a bite. And since coming back, they've then started to get real progressive, severe hip joint pain that feels penetrating deep into the groin. They can't weight bear on it. They've been feeling very feverish, night sweats, hot, chilled sweats. You can start to see they're a bit grey under the eyes. They're looking pale. They've lost their appetite. These type of things, you start to put the pieces together. They could have AVN. They could have septic arthritis. In that instance, we're thinking more an infection, immediate referral onwards.
Yeah, to that immediate referral, I think when clinicians, and I'm kind of talking about myself here, when I may be concerned about something, I'm trying to weigh how immediate or urgent is this. So in this context of you're suspicious of either one, septic arthritis, AVN, or maybe this is a different answer for either one. Are you saying, within today, I want you to call your primary care doctor and try to see them as soon as possible? Or are you saying, I want you to go to urgent care or the hospital right after this conversation? How urgent or immediate are you referring them to the next care provider?
Yeah, so I'll talk about my role as a first contact physio in primary care, where I did have scope to refer on and do whatever. That was just my scope of practice at the time. So if I had that example, if I've got a lady, for example, that she's come in with that exact example that I've just given there, that's very, very concerning for me, because if we're getting to a point now where you can't weight bear on the joint is so painful, but we're also getting fever symptoms, lack of appetite, night sweats. This is where the night pain, lack of sleep, these are all red flags that as physios, we're all taught to screen for. Sometimes we don't necessarily know what it means. We're taught to ask the questions maybe in quite a parrot fashion way, which is okay when we're learning. We have to kind of go through a bit of a parrot fashion learn, but we need to know, what does all of that mean? So if that all comes together into that case scenario I've given, I would be saying you need to go to accident and emergency department. Depends on your systems. I would write, in my role, I would write a very brief letter or a very brief referral form, marking it as urgent, and say, you're to go there now. This has come from me. If you need the GP to quickly sign off on it, that is an emergency of right now. There is no time to wait of book an appointment with your GP to see them next week or whenever it is. If it is an infection, that is just going to manifest. The patient is going to become so incredibly unwell, and it then becomes life-threatening. It's no longer then just about the joint. We're then concerned with the patient's life when we're talking about infection. So there is no time to wait. They need to go immediately right now to get treated.
And maybe you'll discuss this with your case study later, but you're not concerned about that, let's say septic arthritis or immediate infection, but you're just generally concerned about avascular necrosis. Is that similar level of urgency? Is it a little bit tiered down, or is it also just the surrounding signs and symptoms as well?
Yeah, I think with AVN, it really does depend on the symptoms of the person in front of you, on how urgent that you think it is. The case study I'll talk to you about a little bit later is that it wasn't urgent. And I'll tell you why when we talk about it. He wasn't limping, for example, like he was walking okay, but he presented with a few risk factors. He'd had an x-ray which wasn't showing anything. So that told me that, he's obviously not in the mid to late stages of AVN, if it is AVN. So we sent him for an MRI, but he had the MRI the following week. It wasn't an urgent case. It was picked up and it was managed. So you'll get some instances like that. So it is down to the discretion of the therapist to determine how urgent do I feel this is. If we pick an urgent case of an AVN, and we'll just make this up off top of my head, is that if you've got a 50-year-old male that comes in, he's still smoking, he's been having 10 cigarettes a day from the age of 18, he's still smoking, that's already a risk factor. The smoking meant he's been diagnosed with COPD when he was in his late 20s, let's just say. So now he's on a form of steroid medications to help him manage his COPD. So already there, we've got smoking, we've got steroids as a longitudinal risk factor for this particular person. He's come in, he's limping. He's only started limping over the last 5 days, but prior to that, he wasn't limping. He's now getting pain at night, and the hip pain is waking him up anytime he moves, gets in and out of bed or whatever. He's had to resort to using a crutch of some description because he simply can't ambulate. The pain is just intensifying. It's spreading into his groin, his genital region, his buttock, down his thigh. He's got a significant loss in range of movement, actively and passively at his hip joint. That shows a quite quick progression of symptoms with two very significant risk factors with this mnemonic. I would want him to get an MRI much more quickly. So ideally within that day, if we can, or certainly within the next couple of days, we need to get an MRI. So that would be an example of something a bit more urgent compared to my case, which I'll talk about wasn't as urgent as that.
Okay, got it. Yeah, that's helpful. Thanks for that other scenario or image. Let's go into rheumatological disease and radiation. And the rheumatological, that may be you reiterating some of the things previously with steroids, but anything you also want to add, and then going into radiation after that.
Yeah, I think the rheumatology we've spoken a lot about, so I won't touch on this too much because I think a lot of us will know that the inflammation, vasculitis, so inflammation to the blood vessels, that's going to damage the blood vessel lining, which we've spoken about. That will affect the blood going to the joint, to the bones. There is a hypercoagulant effect with rheumatological diseases. So the chances are someone with rheumatoid arthritis, for example, the clotting factors in their blood are going to be elevated compared to ours, or me. I won't talk about you, Chris, but me that doesn't have a rheumatological condition, their clotting factors will be much higher than mine. So again, clotting within blood vessels can stop blood flow to the joint. But the medication effects, which we've already spoken about, so steroids becomes almost a conjoint risk factor. So RA, for example, with steroids, I think that's two risk factors into one that come together, which we've spoken about. Radiation exposure, and I think a lot of people think about this in oncology, naturally so. So people that are oncological patients or recently undergone chemotherapy, radiotherapy, for anything in particular. But also if I would also use the example if over a period of years, so I'm now more thinking about maybe someone who's in their 60s or 70s, and they were to say to me they've had a lot of x-rays over the decades. It's a similar way to the steroid use, isn't it? Of if they've had lots of exposure to radiation over many, 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 many years, as opposed to someone that was diagnosed with breast cancer, for example, and they had a lot of radiation exposure over a shorter time frame. Both can be sort of their own risk factors. So again, it's just about inviting them to share a bit more of their story and finding out how much radiation exposure they've had over what time period is probably quite key. But the radiation exposure will do one main thing actually, and it reduces bone turnover. So we're taught in university our osteoblasts, osteoclasts, and turning over bone tissue. So the efficiency of that process reduces massively if someone has had significant radiation exposure in a short period of time or a long period of time. So effectively, it reduces the bone's ability to repair. So any micro damage that's happened to the bone or during that bone turnover process, we could argue, and we know this actually, that they're much more at risk of getting osteopenia, osteoporosis. So in relation to, if I draw it back to an original question you asked me, Chris, about bone stress injuries, and we're talking about insufficiency fractures. And so if we're talking about the older demographic, if they have had radiation exposure, and let's say they've done a fair bit of smoking in their time, they're both risk factors for reduced bone mineral density because of the fact they both impair bone's ability to turn over new cells, new bone tissue. So the bone's effectively weaker. It's the same thing that happens with the radiation. So if the bone is already in a weaker state, the chances of it losing its structural integrity and collapsing also increases. So it's no longer just a vascular input, it's also structural integrity of the bone input as well.
Let's go to S, sickle cell. I think you had mentioned that's been pretty uncommon, at least where you were in the UK, but what is it generally, and then how is it a risk factor?
Yeah, so where I was in the UK, this wasn't something that I very commonly see. But as a demographic, sickle cell disease, I suppose, is more prominent in the African Caribbean populations. There will be places in certain parts of Europe, like Greece or Turkey or whatever, where it is prevalent. But I would say, for simplicity for today, not having read stacks of research on the epidemiology and demographic of sickle cell, but I think we know that it is more prevalent in the African Caribbean demographic. It's not to say if that person comes into your clinic, we can't judge instantly and think, oh, they've probably got sickle cell. Definitely don't do that. We're not discriminating practitioners here at all. It's just something to have in the back of your mind. That's all it's a case of in terms of demographic. But sickle cell disease is basically where your red blood cells become much more rigid. Rigid. So they're not very spherical. I suppose if you look at it on an image, it looks a bit more indented. If you've got a nice circular red blood cell, on each end, it might have a bit of a dip like this. It might look a bit like that. So a bit more of a bridge, if you like, between the cells. So their circumference effectively reduces. They're not quite as elastic, as I say, they become much more rigid. But effectively, this is where people can get anemia. So the red blood cell is no longer not only able to transport or travel through the bloodstream as well, but it's also not delivering as much oxygen. In some cases, if any oxygen to the blood, to the joint or to the bone. That's what sickle cell disease is in a nutshell. It's a change in the structure of the red blood cell, which means that those red blood cells that are transporting blood to a joint, to a set of tissues, it's not delivering as much oxygen, hardly any oxygen, maybe no oxygen with certain blood cells. So the red blood cell's job then becomes basically ineffective, if you like, for what it's tasked to do.
Not ideal. So we'll go into the last one, and then I want to hear some of your other differentials and then the case study as we round things out. Stairs P, pregnancy. What is the concern with individuals who are pregnant and the risk factor for AVN?
Yeah, this is something that I'd probably say in the research, we just have hypotheses. Because it's so rare, and that's why I just tagged it on to the mnemonic as a P on the end to acknowledge it, because it is very, very rare. And any women, pregnant or not pregnant, listening to this, I don't want this to be scaremongering because it is so rare. Please take that. I don't want you to be fearful of getting pregnant to have a baby because you think this could happen. It's very, very rare. So please don't let this influence your life decisions on that front. But I think some of the theories that have been put out there comes back to hypercoagulation or hypercoagulability. So during pregnancy, the woman's blood will naturally have more clotting factors, as it should do, because it's basically a part of your body trying to prevent excessive bleeding when giving birth. So because of the fact the clotting factors are that much higher compared to a woman that isn't pregnant, there is a chance that we could get some clotting within our blood vessels, which can then disrupt blood flow to a joint. I suppose, especially in pregnancy, the hip joint becomes it's probably the more likely joint to be affected by AVN. So that's one of the theories that we have. The other one is that naturally, as we'd expect, the increased intra-abdominal, intra-pelvic pressure that naturally comes with pregnancy. So there's a theory that if that pressure builds up enough, similar to when we spoke about intraosseous pressure with the steroids and alcohol, does that pressure cause fatty cell buildup or swelling? And does it also stop blood supply to the bone, to the joint through that intra-abdominal, intra-pelvic pressure? And the other thing, which again is a little bit more loose, but kind of talking about hormone changes and the elastic properties, if you like, women's joint structures and their joint capsules when they're pregnant. Does that have an influence on hemodynamics and possibly how the hip joint is loaded with gait? Possibly, maybe. It's not something that we know a huge amount about. So these are just theories, but the idea is that it's normally a combination of altered hemodynamics and clotting changes as opposed to one singular direct cause and effect that we know, for example, with steroids. So it's a bit more of a loose explanation, I appreciate. It's something that we have to mention, but we also have to acknowledge that this is such a niche, such a unique area that we don't know a huge amount about it.
Outside of the differentials you already mentioned, which was some of the trauma examples, an actual fracture, a hip dislocation, infections, septic arthritis, anything else differentials wise that you think is worth bringing up in this case of someone's presenting with hip pain that maybe we're not thinking of some of these other soft tissue based things, but more intra-articular things that you think is warranted to touch on before we go into your case study?
Yeah, the first one I'll point out is red flags. Sorry to harp on about it, but we always have to think about things like osteosarcomas or an other malignancy, whether it's prostate cancer or anything like that. Any histories of cancers, your red flags will be similar to where I spoke about infections. So I won't touch on all of that again, but if you're screening for all of those red flags and if there's been a history of cancer, we know that is the biggest risk factor to cancer reoccurring. That would be a massive one, which if people are presenting with, it's not your job to diagnose cancer. It's just if you're worried about it and concerned about it, refer on for further investigation. Yeah, we spoke about fractures already and bone stress injuries and septic arthritis. The other one, which I think people are less commonly aware of, is something called calcium pyrophosphate deposition disease. So it's called CPPD. I did a brief Instagram post about this some time ago. It's something that can present very similar to AVN. So where I spoke earlier on clinically, what you could see where you're thinking this is severe hip joint issue, an MRI can help to decipher, is it AVN or is it CPPD? It's essentially calcium pyrophosphate is something that we all have within our joints. It's almost sort of a structure. No, sorry, not a structure. Losing my wording. I'll come back to it. Calcium pyrophosphate is essentially something that exists within all of our joints, and it helps to keep our joints healthy, keep things going okay. When people get a bit older, so typically over the age of 60, and it does commonly coexist in the presence of hip osteoarthritis. It's not just the hip this affects, by the way. It's probably a bit more common in like the wrist and hand places as well, but it can affect the hip. So it commonly exists with osteoarthritis. Those that are over 60 years old, you can get a buildup of these calcium pyrophosphate crystals. So it essentially causes a crystal arthropathy, if you like, within the joint. It's not something that's life-threatening. I wouldn't put it on the same spectrum as AVN, but it's something that has to be diagnosed with imaging and with aspiration injections to get that. So it's not something you're going to see in your everyday, every weekly clinic. But CPPD is a differentiator with hip osteoarthritis. The other one that's big for pregnant ladies, again, it's not hugely common, but it's something that's called transient osteoporosis of the hip, or TOOH, as you might deem it as an acronym. We don't know a huge amount about it, again, because I have to emphasize this to any ladies out there, it is not that common. So please don't let this influence getting pregnant, having children, because it isn't common. But we're not sure if it's down to, again, like the AVN risk, is it down to hemodynamics? Is it down to edema? Is it change in nerve blood supply, change to the structural integrity of the bone, the hip joint? But it's essentially softening of the hip joint where you're getting osteoporotic changes. The bone becomes weaker. The structural integrity and the loading parameters of the joint then change. So you can struggle to weight bear on the joint, lose range of movement. It's very, very painful in the groin. Again, if it's managed, it's not something that can be detrimental to you, but an MRI would help you to distinguish, is this AVN, is this TOOH? Other more common things we know is FAI, labral pathology. They're some of your other differentiators.
Yeah, it's a lot for clinicians to think through. And that's why having these discussions and bringing up all the considerations and all the subjective questions to dive into their past medical history, getting a true picture to, if there are things you're concerned about, to escalate that in the manner that's appropriate, to have kind of a watchful waiting, whatever it is. So I'm thankful for you for creating this mnemonic, and for people to, you can even print it out and just have it with you, or just think through it when seeing patients, whether it's hip related or not. Let's go into the case that you alluded to, the individual that was a little less of an emergent kind of scenario, but you were still suspicious of AVN. Give us this case study.
Yeah, this was earlier this year. It was in my FCP role, primary. It was around April, May time. But yeah, he was in his mid-40s. I can't remember exactly how old he was. So he was mid-40s, but he came in with right-sided hip and groin pain. He was able to weight bear on it. So he wasn't walking in with a limp, but he was complaining that the intensity of his hip and groin pain, it was getting much more and more, and it was starting to refer down the front of his thigh, the inner side of his thigh. That was the initial thing he complained of. He said he had an X-ray, which didn't show much of anything. It showed maybe some very mild osteoarthritic changes in the hip joint, but he was in his mid-40s. I mean, we probably start to see those changes anyway. But the fact that he was getting intensifying pain was concerning him. When I broke down his history, he was a smoker. So he'd smoked, I think I said to you earlier, he started smoking in his late teens. We'll just call it somewhere between 16 and 19 years old, 45 years old. So he was a heavy smoker, kind of, we'll talk 15 to 20 cigarettes a day. So when we're using this mnemonic, smoking is a known risk factor. Because of his smoking, he was diagnosed somewhere in his 20s with chronic obstructive pulmonary disease. So he was on a form of a steroid medication to help him keep his COPD under control. It wasn't saying he was taking every day. this medication, but it was something that he was taking weekly. But given that if we call it mid-20s, he started that medication, he's now in his mid-40s, we've got 2 decades worth of steroid medication that he needed to take. We've probably got pushing on 3 decades worth of him smoking. So when we're using the mnemonic, he's steroid user through prescription, smoking. Those were the 2 risk factors for him. We know that AVN is more common in males. So it's another little sort of side fact. It's not that it doesn't happen in women. It's just more common in men. Why, we're not necessarily too sure. That's probably just where that's what the research demographic has found. When we assessed him objectively, he had a loss of range of movement in actively and passively. So he was struggling to lift his right hip into flexion to put on his socks, put on his trousers, tie up his shoes. So he would have to use his back instead to lean forward to do it. So that's another communication tool, I think, where I've made the mistake before. I've asked people, can you put on your socks and shoes? Because if someone can't, that means there's something probably going on with the hip joint. And people will often say they can, and they'll show you by flexing their spine forward and doing it. What you want to ask them is, no, can you bring your leg towards your chest and do it that way? And that he couldn't do. There was also a loss of rotation, particularly internal rotation, range of movement at his hip as well. So when we put all of that together with the risk factors and some objective signs, I didn't know if he had AVN, but I knew it was the hip joint. I know that X-rays in the early stages of AVN, it can miss it, particularly where we're just talking about edema. So we referred him for an MRI. I did the referral for an MRI for him, and I think he got it 7 or 10 days later, and it confirmed an AVN. It was managed he could manage it conservatively. I wasn't in a rehab role as a primary care physio, so he was with medications. I think his steroid medications were reduced, etc. He was put onto we'll call it a smoking program to help him reduce his smoking. He went to see a physio as well. So it all got managed conservatively. But that's an example of a non-emergent case that I know you asked me earlier. How to decipher if something's emergent, non-emergent. He was non-emergent, but it was AVN.
Those maybe emergent scenarios, the one you mentioned earlier, may be easier to have that discussion because it's emergent and you want them to take action quickly. But in this scenario where you are referring them to an MRI to receive further imaging, it is a high suspicion for you. Do you have any words of wisdom for that discussion of this is initial examination potentially, you just now are meeting this person, but you are suspicious of something that's concerning, you maybe do or you don't want to freak them out, but you want to be serious. How would you recommend clinicians kind of go about tactfully bringing up the discussion of recommending imaging and maybe what's on your possibility of potentials without just really freaking someone out?
Yeah. So the first point, and mentioned it earlier, I've mentioned a lot of differentiators to people, and we hope for this podcast to be educational. I don't give those differentiators to scare people and for you to have that pressure to think, how do I know if this is transient osteoporosis of the hip versus AVN? Look, you're not going to know. How do I know if it's CPPD versus just hip arthritis? You're not going to know. Your job is to ascertain is this the hip joint that is the problem? Let's use my subjective to think, someone's at risk for this, but they also could be at risk for this. Ultimately, I'm not going to know unless we refer on and get an image. That's it. That's the job. And mentioning these differentiators is just to make people aware to hopefully advance your clinical reasoning when it comes to hips in particular. So that's the first bit I want to say, and I'll probably close my final thoughts out on that, Chris. But when you're wording it to a patient in a case like that was non-emergent, you're right in that we need them to go and do it. We need to emphasize it's important, but we don't need to scare them either. Whereas if it's emergent, dare we say we might need to scare them a bit because it's urgent, right? So now in this case, I would say to everyone, your body language, we know that most of our communication is body language. It's not actually what we say. So make sure that you're not looking at the computer, you're talking to them as we are now, you're making eye contact with them, and keep the tone of your voice very calm, very relaxed, how hopefully I am right now, because that will hopefully help to settle them. And you're just having a conversation. And with this gentleman, I said to him, okay, mate, look, what I'm going to do is we're going to refer you for an MRI. I appreciate you've had an X-ray, but I just want to be super, super thorough here and get the MRI to make sure that we are absolutely ruling everything out that could possibly be causing your hip pain. I said, now look, you've acknowledged that you've been smoking for a number of years, and the fact that you're managing your COPD with steroid meds, the fact that your hip pain's been getting a bit worse, and we found this in our objective assessment. We know that something's probably going on with the hip joints. So we're going to send you for an MRI just to check that the structural integrity of your hip joint is okay. And let's assume that it is, and then we can continue with conservative management. How does that sound to you? And he was like, yep, fine, let's go do that. So it's just keeping it very calm, very relaxed, emphasizing we need to do it because we need to rule things out. I've explained to him that's because of X, Y, and Z. And that's it. That's all the conversation needs to be.
When in that scenario, that individual that was able to manage it non-operatively, in his scenario or in those scenarios where they can continue the conservative pathway, what does the data suggest around what are the recommended options there? I think you had mentioned kind of removing or minimizing some of those risk factors that are modifiable at that point in time, and then maybe progressive physical rehab to help get them back to the demands that they need to. But that it sounds like if someone has AVN, it's not every situation in which someone has to go for an emergent procedure, but when they don't need, surgery or changes structurally, what is that general course of timeline and management options? And then when would the scenarios be where they do need to escalate to surgery, and what type of surgery typically occurs?
Yeah, so it's probably three scenarios. So this one, conservative management. So it's because he was in early stages of AVN. The structural integrity of the hip joint was still preserved. That's why the X-ray came out clear. Structural integrity was fine. There was no collapse of the femoral head. So there was some edema. And that's where initially, if you've got a case like that, a lot of it is going to lean heavily on the symptoms of the individual and their functional impairments alongside what the imaging shows. So the extreme example is that where I say if someone comes in and they've been getting very acute progressive hip pain, can't weight bear, losing range of movement, losing functionality, very sad, very upset, losing sleep, etc., and you send them more urgently on for an MRI. The MRI shows a significant edema. The X-ray shows massive structural integral changes to the hip joint and even a femoral head collapse. They're going to need a hip arthroplasty for that because that joint is now so damaged. Chances are they're going to need to have that joint replaced. So that's when you're talking on the route of a total hip arthroplasty. And then they'll be managed with physio afterwards as you would manage a post-op total hip replacement. So that's an extreme example of that. You can have a hip preservation surgery, almost like a decompression type surgery. So that would be where you say you haven't had a femoral head collapse. There's significant edema. The structural integrity of the joint has started to change a little bit. That's where, and this is down to our surgical colleagues, and we have to lean on them massively here for their opinion. Our job is to link the symptoms and their functionality with the image. And if we find, say my case, for example, and you can get cases like this where someone hasn't had a femoral head collapse, the structural integrity has changed a little bit, but their day-to-day function hasn't changed massively. They can still weight bear on the joint. The surgical team might look at that and say, okay, let's clean this up. Let's do a decompression surgery. Let's modify the modifiables alongside that and then do rehab afterwards. The case of like my one, it never required surgery. His joint was okay. So the things that could be modified was putting him into an educational plan, which is where our social workers, occupational therapists came in very handy in a smoking cessation program on helping him to slowly reduce and cut out smoking and putting him in that educational plan. The GP and the respiratory team could then modify his medications. It's their area, whether they change them entirely, whether they reduce the dosage or whatever it is, those are things that are modifiable. Can we as physios help him to change his lifestyle habits? And I can say here that he wasn't the healthiest of guys, even in terms of eating, sleeping, drinking. Those are things we as physical therapists, physiotherapists can help educate alongside the exercise strengthening to improve functionality. So they're probably the three domains that you would sit in, if that answers your question.
That does. That individual, that conservative pathway, assuming their symptoms are improving, their function is improving, their complaints are improving, is repeat imaging necessary, or would that only be indicated to check kind of the status of the AVN if they were having, no improvement of symptoms or a worsening of symptoms or function?
Yeah, definitely. If there was worsening, so if you decided to go down the conservative route, let's say my patient is what it was, had the MRI, and he could be managed conservatively. If we found 6 weeks later, 2 months later, that he's made no improvement, if anything, gone backwards in range of movement, function, pain, then yeah, definitely we would need to get some repeat set of scans because your instinct would tell you the AVN must have progressed or something else is going on that we didn't pick up 6 or 8 weeks ago. So that would be a clear cut, yes, we need to get this looked at again. I would say that most of the time, repeat imaging is very useful. If someone, and this again depends on your context, let's assume this guy wasn't involved in his rehab, but let's assume he did 8 weeks, 12 weeks of rehab. He improved massively, function improved, pain, etc. Everything was nice, linear, upstaging. Probably don't need the imaging because everything has improved. So you probably don't need that repeat imaging in that example. If I had someone that had osteoporosis or osteopenia, where we're not only concerned with AVM, but the effects that AVM can have on the bone and the fact they're already osteoporotic, you may want to get some repeat scans there. So that might include DEXA as well to check the bone density, and then the MRI, the X-rays to check on, I suppose, what AVN could do to the hip. That could be an example where even if they are improving, you may want some repeat scans to make sure that everything is going okay. If it's a post-operative case, orthopedics 9 times out of 10 will want repeat scans. I haven't come across an ortho that won't do that. They will want some repeat scans because you can get post-operative AVN. It's not common, but surgery is trauma. Ultimately, it is trauma to the body. So it does still fall under trauma in the mnemonic. So they'd want to make sure that nothing has nicked a blood vessel and there's no AVN occurring. They'd also want to make sure that there's no post-operative bone stress injuries, or because sometimes as physios, I think we can all be at fault of it from times, is that we can push the rehab quite quick because we want to get on. We want to push and get results, right? And sometimes we can overcook things a little bit, and sometimes we can get post-operative synovitis, a bone stressy or something. So that's where the post-op imaging, repeat imaging will be important. So yeah, again, I know I'm not giving people a script, but hopefully giving people examples of where you may not, like my case didn't need repeat imaging. As far as I'm aware, he was absolutely fine. Post-operative, definitely do. Someone that's got underlying osteoporosis, osteopenia, for example, you'd probably want some repeat imaging. So it's just giving you some examples. It's all about clinical judgment, autonomy at the end of the day.
This was an absolute masterclass on AVN of the hip, but in general for people to consider all of these risk factors throughout the other joints of the body that are higher risk as well. Anything as we wrap things up that you want to summarize or touch on before we close it out?
I'll sound like a broken record, I'm afraid, Chris. But the only thing that I would want to close on, 2 things. One is your subjective assessment is everything, in my opinion. That's 70, 80, if not more % of your assessment. There was an old, can't remember if his name was William Osler or something, but it was a physician that said, listen to your patients because they'll be giving you the answers. And that's something that I often close my presentations, teaching talks about, is spend time listening. What was there? Was there a study some time ago that, I don't know if this is physios, but GPs, that they will let patients talk for 9 or 11 seconds before they interrupt them? Something like that. Let your patient talk, let them tell their story, invite them to speak, and really lean on your subjective, because that's where everything sits. Particularly with cases like AVN, your objective isn't going to do a whole lot. And the second point is, try not to be the superhero. It's not on you. I've mentioned lots of differentials today. You don't need to go and memorize and learn all those differentials. Just be aware of them. Be aware that things can present very, very similarly to AVN. Your job is to be a bit of a detective, make sure your patient is safe, be thorough, refer on, lean on the multidisciplinary team. Don't ever try and be the superhero. It does not sit with you entirely. They would be my 2 messages.
I think that's a great place to stop. Callum, I appreciate you taking the time. Hopefully people find this helpful. I'll direct them to your Instagram so they have further hip resources, and they can also see that initial post that I think you, whatever it's called, pinned in your Instagram as well. We'll call it there. Thanks again.
Thanks, Chris.